At first, I must share my slides. Let's share my slides. Okay. Okay, now you can see my slides. Yes?
No, we cannot see it. Sorry.
Okay.
No, we cannot see it.
Mm.
Ah, yes, now we can.
Now, yeah, thank you so much. Okay. Again, hello everybody, and welcome to our great colleagues that come to our meeting. At first, because we have some guests from other country, let's start with that. This is the 5th meeting of joint meeting of our presentation between Southampton Children's Hospital and Children's Medical Center. And this meeting is held under the supervision or as part of the project, sister project of the PRESS. As you know, PRESS is Pediatric Rheumatology European Society. And we hope that this meeting will be informative and very educational for everybody. Dr. Alice Leahy is focal point in Southampton Children's Hospital, and I am focal point in Children's Medical Center of Iran. Let me first introduce myself. I am Peyman Sadeghi, Assistant Professor of Pediatric Rheumatology, Tehran University of Medical Science, and I'm very glad to have time to present this topic for you. Today, I'm going to talk about MKD. As you can see, this is Mevalonate kinase deficiency. At first, we have case presentation, and then a short discussion by me. And after that, we will have time for question and answers and also discussions from the other colleagues and the other expert. At first, I must say that I invite one of our great and expert colleagues to our meeting. He is Dr. Nima Parvaneh. He is clinical immunologist, and he's one of the best in his field. And we are honored to work with him and thank him to share his case, which has some common aspects with our field to present in this meeting. Thank you so much. Let's start our presentation. Okay, our patient was a female infant. Her age was 5 months old, and she had consanguineous parents. Her chief complaint was prolonged fever. Let me start his medical history a little bit from the past. She had a previous history of 3 times hospitalization in another center before her admission in our center. First admission was for suspicion to CMV infection because of fever. And all the time she had admission because of prolonged fever. First time there was suspicion to CMV infection, so she received ganciclovir. Second admission, again, there was suspicious to COVID infection, so she received azithromycin. And the third admission, suspicious to infection due to phagocytic defect, so she received IVIG, isoniazid, and rifampin for possible TB infection, tuberculosis infection. Also, linezolid and meropenem for possible sepsis. Okay, this admission, I mean this 4th admission in our center.
Simon, sorry, the slides are not moving on the screen.
Okay. Okay, okay. Now you can see the second slide or not?
No, it's only the first slide still.
The first slide.
Yeah,
Okay. Okay, let's see what's the problem. Thank you so much
sorry.
for telling me. Because I didn't know that the slides doesn't move. Okay.
No, not moving yet.
No, no. Okay, okay. Just a minute. Maybe I have to go out of the display setting. We have. Okay, now you have slides or not? The second slide.
This is the first slide, but if you click to the next one.
Okay.
Yeah,
No.
we got
Yeah.
the second one now. Yeah,
Okay. Okay. This is the
perfect.
second one. Okay.
Yes.
This is the second one that I talked to you. Okay. About her previous admission. And as I told you, she had 3 previous admission before her admission to our center. Okay, now this is the 4th admission. She comes with these complaints, fever and lip cyanosis and a few jerky movements in her extremities. Physical examination only showed a little bit hepatomegaly and splenomegaly, maybe because she was very little and we couldn't rely on the physical examination alone. So after that, the plan for this patient was sepsis workup and rule out of seizure disorder because of the movement. As you can see, because of repetitive events with cyanosis and tachycardia and tachypnea at the same time. Initial measures was broad spectrum antibiotic therapy plus anticonvulsant therapy, which concluded phenobarbital and levetiracetam. Okay, these are the initial lab study. As you can see, there was leukocytosis and a little bit anemia, maybe more than a little bit. Here, I must add that she had a history of recurrent anemia and she received multiple units of whole blood to treat this kind of anemia, but still she had anemia even in our center. The platelet are normals. ESR, as you can see, is high. CRP is very high. Liver function test was normal, and the other test or renal function test was normal. And ferritin was a little bit higher than normal, as you can see, 387. All the culture, I mean blood culture, urine culture, CSF culture was negative. Bone marrow aspiration was normal. Bone marrow biopsy was normal, even for malignancy, and also HLH, as you can see, lymphocytic was ruled out. CMV viral load was negative, EBV viral load was negative, and Mycobacterium tuberculosis PCR was negative. And these were the initial lab study that we did for this patient. After that, we had imaging. Chest X-ray showed bilateral parahiral consolidation, peribronchial thickening, maybe due to viral infection. Abdominal sonography showed hepatomegaly, and the size of liver, you can see, 106 millimeter with normal parenchyma. Splenomegaly, and it was 85 millimeter. Brain MRI, as you can see, showed different lesions. As you can see, mild white matter volume loss and irregularity is seen in periventricular region and centrum semi-oval bilaterally, with irregularity of ventricle walls. Corpus callosum is severely hypogenetic and small. Normal myelination process according to the patient's age. Bilateral mastoid effusion. I must emphasize on this term bilateral mastoid effusion. A simple cyst with 2 millimeter diameter in caudothalamic groove. Other parts are normal. Echocardiography was done 4 times for her, and all of them was normal. All of them were normal. Okay. So there were so many consultation for this patient. At first, the infectious consultation, they recommend to change antibiotic to cefepime, vancomycin. Later had blood culture positive for Candida, so they recommended to add caspofungin. Also recommended to investigate for COVID-19, TB, urine VMA, vanillin mandelic acid, as you know, and lung HRCT. Because of some worries about the midline lesions, endocrinology consult was done to rule out midline disorders. They recommend workup for hormones. I mean, growth hormone, TSH, cortisol, ACTH, and all of them were normal. Dermatology consult to rule out anhidrotic ectodermal dysplasia, and again, they ruled it out. And then ophthalmology consult was normal. Rheumatology consult after long period of antibiotic therapy and getting no response, and fever still continues. My colleague recommended corticosteroid pulse therapy plus etanercept plus ibuprofen for possible autoinflammatory disorder and genetic analysis. We did additional tests, immunologic tests. All the CD numbers were normal. I mean, CD 3, 4, 8, 19, 20, 16, 56, and 45 were normal. Immunoglobulins, I must emphasize on the immunoglobulins were normal. I mean, IgA, IgG, IgE, and IgM. We don't check IgD in our country. There's no lab that we could refer our patient to check IgD. So these are the immunoglobulins that we could check. So all of them were normal. Also, complement system were normal. C3, C4, CH50, NBT for ruling some immunodeficiency was normal. You can see 100%. Bone marrow ferrocytometry was normal. Alpha fetoprotein was normal. T cell receptor panel was normal for rule out ALPS, as you can see, autoimmune lymphoproliferative syndrome. Bone scan was normal. After that, the patient was treated with prednisolone, etanercept, and phenobarbital. And after 2 months, the fevers stopped, and the system or the ward could discharge the patient with this prescription. As you can see, prednisolone 5 milligram per day, etanercept 5 milligram per week, and phenobarbital and levetiracetam. You can see the lab study before discharge. WBC was normal, hemoglobin was near normal, platelet count was a little bit low, but still high ESR and CRP. But the patient didn't have any complaint or any symptom or sign. After 5 months of this kind of therapy, because the recurrent fever, etanercept stopped, and anakinra was started for the patient instead of etanercept. Now the genetic study was ready. The genetic study showed 2 heterozygote variant combined heterozygote in the MVK on chromosome 12 to be associated with MVK or hyper IgD syndrome. that was the case, here a little discussion about MVK deficiency, and here I can say that I'm very glad that Hans is here, because I know he had I know he has great knowledge about this disease, because most of the patients are from Netherlands, and Hans could tell us so much about it. Okay, what is MKD, or mevalonate kinase deficiency? It is a rare autosomal recessive autoinflammatory disease caused by loss of function mutation in both allele of MVK. MVK, the gene encoding the enzyme mevalonate kinase, which lead to impaired isoprenoid biosynthesis. The endpoint of this malfunction is activation of pyrene inflammasome and oversecretion of interleukin-1 beta. Okay, you can see this picture. This is where the mevalonate kinase is used in this process, and in this disease, mevalonate kinase deficiency. The deficiency of mevalonate kinase could have two results. First, accumulation of mevalonic acid, and the second is some kind of deficiency of granular pyrophosphate. And most of the symptoms and signs of the patients are related to these two processes. I mean, accumulation of mevalonic acid and some kind of deficiency of granular pyrophosphate. And as you can see in this process, there are some enzymes which could be stimulated or inhibited by other drugs like statins or bisphosphonates. I use this information later. Okay, interleukin-1 is an important mediator of inflammation in mevalonate kinase deficiency, but the result with interleukin-1 blockade was not very favorable as the other interleukin-1 diseases, related disorders. For example, we can say CAPS or cryopyrin-associated periodic fever syndrome. So we believe that the other cytokines maybe contribute to the pathogenesis of the disease, or and they can use for preventing symptoms. These factors are serum gamma interferon, TNF alpha, and interleukin 6. Here you can see the spectrum of the disease. The disease have two spectrum, and it's related to the enzyme activity. When the enzyme activity is a little bit lower than normal, we have MKD, or mevalonate kinase deficiency disorder. We called it hyper IgD syndrome. Here we have the inflammatory attacks like fever, lymphadenopathy, gastrointestinal symptom, aphthous, ulcers, rash, arthralgia, and arthritis. Yeah, the other end of the spectrum, we have total lack of activity of the mevalonic kinase enzyme. So we have mevalonic aciduria. These patients are severely affected. Patient may have neurological involvement, progressive cerebral ataxia, psychomotor retardation, dysmorphic faces, liver dysfunction, hematological abnormalities, cataract, uveitis, and failure to thrive, and often dying in the early childhood. But sometimes we have patients which rely between these two ends of the spectrum. So they could have some symptoms or sign of this end of the spectrum, and or the other end of the spectrum. What's HIDS or hyper IgD syndrome? HIDS is a disease characterized by exacerbation, commonly described as fever, inflammatory attacks, and symptom-free periods of remission. The usual age of onset is before the end of the first of life. A typical inflammatory attack most of the time lasts about 4 to 6 days. On average, attacks occur every 4 to 6 weeks. This disease has common manifestation and rare accompanying signs. Common manifestations are lymphadenopathy, splenomegaly, hepatomegaly, abdominal pain, diarrhea, vomiting, as you can see, articular signs, skin rashes and skin signs, aphthous ulcer, and some neurological signs like headache, some signs related to the eye, and also pharyngitis. Rare accompanying signs are pericarditis, MAS, as you know, erythema nodosum, uveitis, and protracted fever and inflammation. Our patient had these symptoms and signs: protracted fever and inflammation, splenomegaly, and hepatomegaly. Some patients have some degree of immune deficiency, so may have recurrent infection like otitis media, sinusitis, and pneumonitis. I already told you that our patient have had some effusion in his mastoid sinus. Growth and development in the children with pure HIADS, I can say pure HIADS, is typically normal. For a short break, I can show you this picture. These are the rash of the hyper IgD syndrome patient. As you can see, it is like maculopapular rash on the skin. And these are the typical rash of the HIDS. What we must do? Laboratory investigation for this patient are these. Most of them have high concentration of acute phase reactant, especially during attacks. I mean ESR, CRP, and serum amyloid A. Leukocytosis with distinct neutrophilia. Many patients with MKD have high serum concentration of IgD or IgA. But as I told you before, our patient didn't have high concentration IgA. Serum IgD or IgA concentration are not correlated to disease severity. And there is no rule for repeat measurement of these immunoglobulins in the routine follow-up. How could we diagnose this disease? The first step is taking a detailed medical history and preferably seeing a patient during an inflammatory attack. During an inflammatory attack, an acute phase response should be detectable. So this is necessary for the patient have high concentration of acute phase reactant. If there is no raised CRP, the diagnosis of MKD can be excluded. Intermediate step is serum IgD or IgA concentration, but sensitivity and specificity are low. The diagnosis of MKD can be excluded in patients who had their first fever attack at age of 5 years or higher in combination with an attack during of more than 40 days or absence of joint pain. But this explanation is just for pure HIDS patients. MKD has some criteria. This is one of them. As you can see, this criteria gives point to every symptom of sign or the patient history, or and we can count these points. As you can see, age at onset under 2 years, aphthous stomatitis, generalized enlargement of lymph node, painful lymph node, diarrhea, persistent diarrhea, and abscess of chest pain. And each one of them has some special point. When we add all of the points, at a cutoff of sum of 42 points or set of criteria, we can call the patient that has MKD disease. This criteria has a sensitivity of 93% and 89%. These criteria should only be used after careful exclusion, like other autoinflammatory disease of other causes of fever, like infectious immunodeficiencies, malignancy, or other immunological condition. Mm, After the diagnosis, I bring two articles that we could use for the diagnosis and treatment of this patient. First is the consensus protocol for the diagnosis and management of the hereditary inflammatory syndrome. As you can see, it has um, it written in Pediatric Rheumatology to 2020. And here you can see the clinical phenotype for the MKD HIDS, mevalonate kinase. We check inflammatory markers. These markers should be elevated um, during the attack. We should consider the differential diagnosis. And the last step is genetic test that we can use, whole exome sequencing for the diagnosis of this disease. Okay. To confirm a diagnosis of MKD, it's necessary to either find evidence of decreased MK enzyme activity or detect two pathogenic mutation in the gene for the enzyme. The preference for either method depends largely on availability of diagnostic tests in every area. No need no need to do both of them. There are two methods that we could use to examine MK enzyme activity. First, to determine the amount of mevalonic acid, the substrate for mevalonate kinase in the urine. In the patient with the HIDS phenotype, the mevalonic acid spikes in the urine will only be detectable during an inflammatory episode. The other method is to determine enzyme activity directly in patient-derived cell lines, such as EBV-converted lymphoblast cell lines or immortalized fibroblast cell lines. This method is only done in research lab. The first method is used more regularly by the physician to diagnose this disease. For the treatment, what we can do, control of inflammatory episodes. First, we can use NSAIDs, non-steroid anti-inflammatory drugs. These drugs may provide symptoms relief during inflammatory episode, but do not shorten the episode, especially in children. In this group, we can use sometimes short-term corticosteroid. IL-1 inhibition is currently the most effective treatment for the inflammatory symptoms in MKD. We can use IL-1 inhibition in two different ways. First is on demand, when the patient has attack. Patient with relatively infrequent episode starts anakinra at the first sign of the prodrome signs, and use these drugs, anakinra, only during the attack. The second way is continuous treatment. Patient with frequent episode. And what is frequent episode? It means more than one episode per 4 to 6 weeks. We could use continuously interleukin-1 inhibitors like anakinra. There are two drugs which we can use. First is anakinra. You can see the dose in adults, and in children the starting dose is 2 milligram per kg per day, and then may increase to 5 to 8 milligram per kg per day. But as you know, the patient has to get injection every day, and the injections are very painful for them. So most of them don't like this kind of treatment. The other drug is canakinumab. Canakinumab used 2 milligram per kg, then increased to 4 milligram per kg based on the patient's response for those weighing under or equal to 40 kilogram once per month. As you can see, every 4 weeks. For this kind of treatment now is approved for patients over 2 years of age. In patients with MKD who do not respond to interleukin-1 inhibitors, we can use other drugs to inhibit TNF alpha, for example, etanercept or adalimumab, or IL-6. IL-6 we can use for inhibition of IL-6, we can use tocilizumab. Efficacy of these inhibitors has been shown in several case reports and in the Eurofever data. So we use these drugs because at that time we didn't have access to IL-1 inhibitors like anakinra or canakinumab. So we decided to start TNF inhibitor for our patients. Okay, this is another consensus protocol for diagnosis and management of these diseases. This algorithm is very useful. I wanted just to show it, and then you can refer to the original article. This is done by Dr. Hansman and his colleague. And it has been published in Pediatric Rheumatology 2020. As you can see, there are two types of treatment for the disease: on-demand therapy and continuous therapy. And if there is no response, we have to evaluate the patient again and use some other drugs like TNF or IL-6 inhibitors. And also find this article, it's very practical. The topic of the article is management of mevalonate kinase deficiency, a pediatric perspective. And it has been published by on 2020 by Dr. Frankel, and I know he's working in Netherlands, and I have already met him. A very nice guy and happy guy. He recommended to use at first the very usual drug like the NSAIDs during attacks. And if we have frequent attacks or incomplete recovery in between, we have two options. First, add glucocorticoid during attacks, or starting maintenance dose of interleukin-1 inhibitors like canakinumab, or if unavailable, anakinra. Dr. Frankel suggested that canakinumab is superior to anakinra. And if we have access to canakinumab, it's better to use this drug. And if we don't have access, we can use anakinra. Okay, again, there are two types of use of these drugs: on demand, it means during attacks, or continuous therapy. And if we see failure to this kind of therapy, I mean IL-1 blockade, we can use maintenance dose of TNF alpha inhibitors like etanercept or IL-6 inhibitors like tocilizumab or glucocorticoids. Okay, back to this process for the action of the mevalonate kinase. There were two studies using statins. I have already told you that we have two problems. First, accumulation of mevalonic acid, and the second one is is the deficiency of granular pyrophosphate. So, there were some studies that that examine these drugs, I mean statins, for the stimulation of HMG-CoA reductase, and also bisphosphonate for stimulation of this enzyme to make more granular pyrophosphate, or statins for producing less mevalonic acid in the body. Treatment with statin is now not recommended in MKD, because they showed that there's no benefit in using statins for treating this patient. One case report show a good effect of weekly oral alendronate in a 14 years old patient with MKD phenotype. And the last option for this patient is stem cell transplantation. Unfortunately, I must say that we have another patient with this diagnosis, and we did a stem cell transplantation for him, but he died last month. So I canceled the presentation of that patient. And about this patient, we have a plan to introduce him to the stem cell transplantation ward, and do this procedure for this patient again, because she didn't show good response to our medical therapy, and we have to use the last option also for her. What is the complication? About the complication, I can say the most important complication of this disease is amyloidose AA. It's rare but severe. For follow-up this complication, we have to do annual urinary analysis for early detection of proteinuria. Thank you so much, and that was my presentation. I hope that was educational and informative for everyone. Thank you so much. I stop sharing my slides. Now it's time for Dr. Leahy sent a message, lost her connection.
Yeah, I think the internet is pretty bad in Southampton at the moment.
Okay.
So she just drops out and then trying to reconnect every time.
Okay. Sorry for this technological problem.
No, it's not from your side, because from where I am, it's perfectly clear and understandable. So that no problem at all.
Okay.
Yes,
Now,
and another place in England also had fantastic connection. So thank you for a very interesting presentation.
okay. Now I can ask my dear colleague, Dr. Parvaneh, to talk about the patient and his idea about the management of the patient, and also the difficulties in the way of the diagnosis of this patient. Dr. Parvaneh.
Okay. Thank you, Peyman, for the nice presentation of the case and review of MVK deficiency. To summarize, the initial presentation was indicative of an autoinflammatory disorder after excluding other causes and getting the whole exome sequencing results that showed MVK compound heterozygous MVK mutation. I've started on demand anakinra at dose of 2 milligram per kg per day, and then increased to 8 milligram per kg per day. and low dose dexamethasone every other day. And the mother starts treatment at first symptoms for 5 to 7 days. On this treatment, the patient showed partial response with fever attacks every 1 or 2 months. So I would like to know the suggestions of our colleagues regarding the stepping up of therapy and what are the choices for the patient who fails on demand IL-1 blockade.
Okay, thank you, Dr. Parvane. We can listen to the other experts' idea. I mean, I have already told you, maybe Hans has great idea about the disease and diagnosis. And there is a question in the chat box, and it is, if using anakinra during acute attack, how long would you use it for? Dr. Parvane, do you have any idea about it?
For this patient, we use for 5 to 7 days at the onset of each fever attack.
Okay, so we can use it until the fever subsides and the other symptoms, the patient become symptom free. So that's a good time. And I also told you that every attack takes 4 to 6 days. So we can use on-demand therapy for this period of time. I mean, 4 to 6 days.
I have another question. So
okay,
I'm not completely aware of that, but is there a relationship between the kind of genetic abnormality or gene defect you have and the way they respond to therapy? Because it looks like some of them respond well to NSAIDs and some of them do not, and some of them respond really well to anti-IL-1. Is there a relation with the genetic defect that we know of?
I cannot say that there is a relation between the mutations and the symptoms of the patients, because I didn't find anything about this topic, that there is a relation between this. But I can say they showed that every mutation is not really can completely destroy the function of the enzyme.
Exactly.
We have partial dysfunction of the enzyme and complete dysfunction of the enzyme. So this is why we have a spectrum of the disease, that in one end we have complete dysfunction of the enzyme, and in one end and another end of the spectrum we have just periodic symptoms and sign, and not completely fixed symptom or organ dysfunction or signs in the patient. I can say just like this.
Yeah, I see. It's very interesting. It's a very interesting disease, and like you said, in the Netherlands, there seemed to be an area where it's quite a religious area where people, they stick together and they marry in families. So you got lots of consanguinity, and that's the problem.
You know, I saw a static. There are only 200 patients reported in the whole world of this disease, and 75% of these patients are from Western Europe, and 50% of these patients are from Netherlands.
Yeah, and they're all in the little area in the middle of the Netherlands, close to where Dr. Frankel is working.
Okay. So that's why he has great idea about this patient.
Exactly.
I think he works in Utrecht. Yes.
Yes, he does. Yeah,
Yes.
yeah.
Yes. Okay. So let me check chat box. I mean, Ali sent a message for Kirsten that you see many of these at
Great Ormond Street.
yes. We have not seen any in the last 12 years in Southampton.
Yes, I think Alice is.
Okay.
I was working at. Sorry, I put my video on. I've been working at Great Ormond Street for the last 4 years, so we did have a couple of cases. They were treated with canakinumab successfully, continuously. So we did not do the interval therapy, but these were smaller children, and I think it was felt not the frequency of their attacks warranted regular treatment rather than the on-demand treatment that has been suggested. Yes, I think we were lucky because we had canakinumab available and did not have to start them on an anti-TNF, so they were treated straight away with this. They were doing well, the 2 cases I saw, and did not develop amyloidosis. As you pointed out, this could be a side effect. But on the whole, of course, even in England, it's a rare disease compared to Holland. So I think Hansa will have more experience with them. Yeah, but it was a very interesting presentation, very thorough, and of course we are lucky we get the IgD measurements here, and I think it is considered you don't actually need to do the genetics once you have a high IgD. Even though at Great Ormond Street we love genetics and we've done them on everyone, of course, purely for interest rather than making the diagnosis. Yeah, but I think I can't contribute anything more exciting because you've basically exhausted everything. You've given us all the information there is to know. Thank you very much.
Thank you so much for your great summary.
So do I understand well that you have about 10 cases in your center? Because that's what Vahid is saying, isn't it? So are they all from the same area, or is it?
Yes, but we didn't do genetic test for every one of them, and we have to prove that we think that most of them have hyper IgD syndromes, but now the genetics test is more available in our country, so we can do genetics test for most of them and prove that they have hyper IgD syndrome.
Yeah.
And as you can see, Vahid wrote about 10 cases. It's not exactly, yes, it's not exactly 10 cases, but these 2 cases has been proved that they have hyper IgD or MKD disease.
Yeah.
Okay, we have a question from Dr. Nina. Do you have any experience regarding hematopoietic stem cell transplantation in MVK deficiency? Maybe dear colleagues in another countries.
There's a problem with your SIM card. To continue, you'll have to turn on
In
Wi-Fi.
Netherlands or England, do you have any experience in bone marrow transplant or hematopoietic stem cell transplantation?
I did one 10 years ago.
Okay.
During my training. So in Utrecht they do stem cell transplantation for metabolic abnormalities.
Not for this disease, for another disease, yes?
Well, only in extreme cases, isn't it? If you can manage without, then I mean the risks of a stem cell transplantation is still high.
Yes, we did for one of our patients, and Unfortunately, he rejected the transplant.
He rejected it even, yeah.
Yes, the transplantation, and then he died of opportunistic infection 1 month ago, and that was very difficult for us.
Yeah.
But there is no other way when the patient has no response to the medical therapy. I mean, IL-1 blockade or IL-6 or TNF.
Yeah, yeah. When you're stuck,
we have
yeah.
to.
Yeah,
Yes.
yeah, exactly. Yeah, that's the same. That's the same for me. Yeah.
Dr. Sadeghi,
Yes. Yes.
I have a comment on MVK
Yes.
deficiency.
Yes.
We have another patient.
Let me first present you. This is Dr. Wahid Ziai, chief of our ward, and now he has a comment. Thank you so much, Dr. Wahid Ziai, to share your experience with us. Okay.
As you write, we have about 10 patients approved by genetic study in our center. We had a report on a patient, as you can see in a slide share. We have another patient. He has about 10 years on treatment with etanercept and statin. Statin is another treatment for mevalonate kinase deficiency and hyper IgD syndrome. This patient, Dr. Parvaner can explain another patient we report in journal clinical immunology.
Okay, as you can see, this is an article from Dr. Ziai, intermittent neutropenia as an early feature of mild mevalonate kinase deficiency. And they have good experience of using statins to control the symptom and sign. Okay, thank you, Dr. Ziai, to share your experience with us. There is another question. Do you test for urinary LTE4 as a possible biomarker? Unfortunately, we don't have these tests in our country. Maybe some in experimental laboratory, but we don't have these tests. I mean, urinary LTE4 in our center. So I must correct myself that all the 10 patients, I mean, about the 10 patients have genetic study and approved by genetic study. So that was my fault. Please excuse me, Dr. Ziai, and thank you so much. Okay, I cannot see Dr. Lehi. Maybe.
I think she's given up on the internet.
Yes. So is there any question or any comment?
Oh, thank you very much. It was an excellent presentation.
Thank you so much for listening for my presentation. I know because sometimes it's difficult to present in another language. Please excuse me for my possible mistakes. Thank you so much. And if there is no comment or question, okay, we can end this meeting. Thank you all from around the world. I can say around the world. We had guests around the world, and you from Netherlands, Dr. Lehi and her colleagues from England, and many other colleagues around the world. Thank you for listening to my presentation. Goodbye.
Thank you very
See
much.
you.
Thank you.
Next
All the
time.
best.